Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is part 5, the final component of chest X-ray interpretation, looking at invasive line, tube or tool placement. The objective for this session is to review and identify the correct and review the incorrect placement of invasive lines, tubes or tools which have been placed onto or introduced into the body and are seen on a chest X-ray. Okay, let's review and remember. ECG electrodes are attached to the skin, which are able to detect electrical currents in order to provide us with information about the heart. We're not looking at electrocardiography here. That's another Learn Shop. A chest X-ray, however, is a fast and painless imaging test that uses certain electromagnetic waveforms to create pictures or images of intrathoracic structures in or around the chest. There's our chest X-ray. That's what we want to see. Therefore, if we're using ECG electrodes, they have to be placed on the chest correctly. Otherwise, it can interfere with the image that's being created. ECG electrodes, which are placed correctly on the chest, create an image which is not affected by artifact and leads to accurate interpretation of the image by whoever the reviewer is. As you can see, the ECG electrodes should be off the chest. Again, the ECG electrodes, this is a 5-lead system. The previous one was a 3-lead system. The ECG electrodes should be off the chest. Even that 5th central electrode on this image here that is placed over the heart should not be there. It should be removed for the purpose of the chest X-ray. Incorrect placement of the ECG electrodes can affect the direction of the beam and could create potential artifact on the film. Artifact created by non-anatomical objects that are external can lead to an image that isn't actually accurate, and this can lead to misinterpretation or diagnosis when using the image. So keep the electrodes off the chest. So, correct nasogastric tube placement. All these tubes which are placed correctly should remain in the midline when looking at the chest X-ray, as indicated by the arrows. And it should exit level to the diaphragm. The tube should bisect the carina as it goes down, which is typically located at T4. The tip of the tube should be clearly visible below the left hemidiaphragm. All tubes, nasogastric, oral, enteral, have got a radio-opaque tip which can be identified. And most tubes today have a radio-opaque line that allow you to follow the journey of the tube into the stomach or further. As is indicated, radio-opaque line, midline bifurcates or bisects the carina and enters the stomach approximately level to the diaphragm. Radio-opaque tip at the end. Incorrect placement of a nasogastric tube, whether it be nasogastric, orogastric or enteral, if they're placed incorrectly, they're potentially dangerous if their location hasn't been identified either using physical examination or the chest x-ray, which is considered the gold standard. Here's an example of a tube called in the oropharynx, which not identified could result in problems, especially as you start feeding and they can't protect their airway. Here's an example of a tube going to the right main bronchus, into the lung, located at the right hemidiaphragm. Potentially dangerous if you want to start feeding. Inserted into the left main bronchus. Again, potentially dangerous. All tubes have got a radio-opaque tip, or most tubes have got a radio-opaque line that goes along the whole length of the tube. Here's an example of a patient who had a feeding tube inserted into the right main bronchus, right lower lung, and feeding was commenced, which resulted in a right middle lobe and right lower lobe chemical pneumonitis. The patient wasn't very well. Okay, let's review and remember central venous catheters, CVC. Central venous catheters are used for a number of different reasons, one of which could be for measuring central venous pressure. But essentially these are tubes that are catheters which are placed into a large vein and are typically located just outside the heart. Central venous catheters are also known as central lines, a central venous line, or central venous access catheter, and they can be used to measure pressures, central venous pressures, CVP. They can be used for IV fluids, or they can be used to give medications. If the central venous catheter has been placed incorrectly, it's potentially dangerous. And if you're measuring pressure, inaccurate. Here's an example of a right subclavian vein insertion. The central venous catheter hasn't ended up at the cavo-atrial junction. Instead, it's migrated towards the left subclavian vein. So therefore, pressure measurement would be inaccurate, and certain medication administration may be potentially hazardous to the patient. Here's an example where you've got a right subclavian vein insertion and the catheter is migrating up into the right jugular vein, which is heading towards the head. So therefore this could be potentially dangerous if infusing a vasoactive medication towards the head or an oncology medication towards the head, or you wanted to measure the central venous pressure, which would be inaccurate. Okay, let's look at pulmonary artery catheters, sometimes referred to as Swan-Ganz catheters. So let's review and remember certain components. A pulmonary artery catheter is a flow directional catheter. It's got a little balloon on the end of it, which is inflated intermittently to move it into the correct position to give the physician information about the patient's heart function, blood flow, cardiac and pulmonary pressures. So it's a catheter that's passed into the right side of the heart and ultimately into a pulmonary artery, right or left, depends on where the catheter wants to go. And as I said, it provides data about the heart's function and pulmonary blood flow. It can also be used to administer IV medications and fluids depending on the type of catheter. There are some that can actually measure the saturation of arterial blood. Depends on the catheter. So if it's placed correctly, the tip of the catheter should stop about 1 centimetre before the sternal midline. Have a look at the chest x-ray. The dotted line is the sternal midline. So the catheter that you're seeing on the x-ray is deflated. It's just resting there. And if it rests there, it can't obstruct any of the pulmonary arteries or arterioles accidentally and cause pulmonary ischemia and infarction. So it's resting comfortably there. And if it's resting in the right place, it should be level with the carina at T4. However, if the catheter does pass the midline, it shouldn't do so more than 1 centimetre past the midline. If it does, it could potentially obstruct a vessel, which could cause pulmonary ischemia and possibly infarction. There's an example of a catheter that is going in the opposite direction, towards the left pulmonary artery. Still level with the carina, still approximately 1 centimetre before the sternal midline. This one going to the right pulmonary artery, but again 1 centimetre below or before the midline, but certainly not 1 centimetre past the midline. If the pulmonary artery catheter is placed incorrectly, they're potentially dangerous. And why are they dangerous? Because remember, they're going into the lungs, into the pulmonary artery, into a possible tributary or a small arteriole. And if that happens, the catheter, though small, can obstruct, cause pulmonary ischemia, cause pulmonary infarction. If it's in too far, this is greater than 1 centimetre past the sternal midline, which this one is. Have a look at the x-ray. The tip is about 1, 2, 3, 4, maybe 5 centimetres, maybe 6 centimetres. It's in too far, into the right pulmonary artery. And it's not the pulmonary artery, it's a tributary that it could obstruct, cause pulmonary ischemia, pulmonary infarction. Here's another example. It's in way too far. So it's in too far, well past the 1 centimetre midline. This is potentially dangerous. And if, for example, here, someone were to inflate a balloon with the catheter in this position, it would probably cause pulmonary vessel ischemia and probably rupture, and possibly catastrophic pulmonary hemorrhage. Tracheal tubes on chest X-ray. Tracheal tubes, remember, is any tube, whether it's now endotracheal, whether it's orotracheal, whether it's nasotracheal, whether it's a tracheostomy tube. This is a tube that's passed into the upper airway or into the trachea directly through the skin. And the purpose of a tracheal tube is to allow ventilation to occur, whether it's manual with a bag device or whether it's with a mechanical ventilator. But both allow artificial breathing. An endotracheal tube is also radio-opaque. All invasive lines that are placed into the body are radio-opaque. They can be seen on a chest X-ray. If you have correct placement of a tracheal tube, this is when the tube is correctly placed. The tip of the tube should be approximately 5 to 7 centimetres above the carina. Look at the chest X-ray. Carina, we said, was typically located at T4, or you can see it because of the air bronchogram that it normally employs by bifurcating. You look at the tip of the catheter, and the catheter tip should be about 5 to 7 centimetres above the carina. Now, as a rule of thumb, not a true rule of thumb, but as a sort of rule of thumb, if you see the endotracheal tube tip, it should be in the vicinity around the medial ends of the clavicles. And that should indicate that it is placed correctly. Incorrect placement is potentially dangerous. If it's too high, it will probably be above the vocal cords, which means the tube won't be doing what it's supposed to do and you won't be able to ventilate the lungs. If it's in too deep, it may go into the right main bronchus, typically, or the left main bronchus, and that will only ventilate one lung. And if you're only ventilating one lung, this could cause barotrauma of the lung being ventilated, or it could cause atelectasis and lung collapse of the lung not being ventilated. So it's important that the tube is in the right place. What you can see in this X-ray is that we've got the tube is going down the left main bronchus. It's only ventilating one lung, which will cause the lung to be hyperinflated, which it is. Look at the intercostal spaces. Look at the size of the lung. However, the lung on the right side is being underventilated. Look at the intercostal spaces. Look at the air entry. And there's atelectasis occurring. Look at this chest X-ray. This is typically what would happen because of the location now of the right main bronchus in relation to the trachea. It's in more direct route, so typically if the tube is in too far, it will go into the right main bronchus. This one is. It's going into the right main bronchus, and as a consequence of that, have a look. The left lung is all white. And the reason it's all white is because it's not being ventilated. And because it's not being ventilated, it's not getting any air. And any air that remains in that lung will be absorbed. And the lung will become atelectic, it will collapse. It's not being ventilated. Here's an endotracheal tube tip that's too high. And because it's too high, you're not going to be ventilating the patient correctly. Or, if it's too high, there's the potential that the tube can be displaced above the cords, the vocal cords, and result in failure to ventilate. Or, it could be easily dislodged, extubation. Let's look at chest tubes. And remember, chest tubes are tubes that are inserted into the pleural cavity or the mediastinum or the pericardial cavity. And their purpose is to drain air, fluid, or both. Fluid could be pleural fluid, pericardial fluid, could be plasma, it could be blood. And all these tubes are connected to underwater seal drainage, which we're not reviewing in this session. They're catheters that are inserted either into the pleural cavity, the mediastinum, or the pericardial cavity. If the tube is correctly placed, then after placement, there should be a consequence. So if it was placed for pneumothorax, you should see air escape into the underwater seal drain. If it's been placed there to drain blood, you should see blood there to drain the hemothorax. If it's been placed there to drain a pleural effusion, you should see drainage. So correct placement if the air, blood or other fluid are drained. And these can be drained from the pleura, the mediastinum, the pericardium. And on the chest x-ray you should see the tip. Remember, all invasive tubes are radio-opaque. You can see on this x-ray, this infant has got two tubes bilateral, probably because of the position, because of bilateral pneumothorax. If you look at the skin, he's got subcutaneous emphysema in the peripheries. So that's probably the reason why it was inserted. And what should have happened is the air should be draining out into the underwater seal drainage collection chamber. Here's an example where the lateral chest x-ray has also been taken, which we're not going to review, but the lateral basically confirms that something has happened or placement is correct in comparison to the antero-postero or the AP. And again, judging by the placement of the catheter into the apex and the upper lobe, this is probably to drain pneumothorax air, which it seems to have done because the pneumothorax seems to be resolved. Incorrect placement of the tube is potentially dangerous, because if it doesn't do what it was supposed to do, I mean, putting a tube into the chest is hazardous enough. This can cause bleeding, this can cause infection, this can cause trauma. So the tube has to do what it's supposed to do. If it doesn't drain, whether it's air, pneumothorax, fluid, effusion, fluid, hemothorax, fluid, tamponade, then that's potentially a problem and has to be repositioned by the physician. On the chest x-ray that you're looking at the moment, the tube's been inserted for a pneumothorax, which is still there. You can see the upper lobe is mainly black with no vascular markings, so it hasn't done what it's supposed to do. But as you can see, the tube has got a radio-opaque line, tip, which can be identified where it is. So the tube just needs to be repositioned. Here's an example where the tube was inserted for a pleural effusion, or a hemothorax, or to drain some sort of fluid. But it doesn't seem to be doing what it's supposed to be doing. The tube, because again this chest x-ray would have been taken after the tube had been placed to see the position of the tube and to see whether it drained the hemothorax, or enough of the hemothorax, or enough of the pleural effusion. It hasn't done what it's supposed to do. The pleural tube is not in the pleural cavity. The pleural effusion remains unresolved. It's not in the right place. Now let's review transvenous pacemakers. A transvenous pacemaker can be identified on chest X-ray. And this is where the catheter electrode is passed into the right side of the heart, right heart catheterization, jugular vein, subclavian vein, and into the right ventricle. And it's also called endocardial pacing. And it's potentially a life-threatening intervention which is used primarily to correct profound bradycardia. Transvenous pacemakers can be temporary or they can be permanent. And as I said, this is where the electrode is passed into a large vein, a central vein. Temporary, typically internal jugular. Permanent, subclavian vein. Now, correct placement for transvenous pacing electrode for the right ventricle pacing electrode, it should be located, the tip should be located in the right ventricular apex. And even though I haven't provided you with a lateral film would be used to confirm placement as well. This is just an AP film. And on an AP film, the tip of the catheter is located in the right ventricle, making contact with the apex. Okay, let's move on. Review and remember pigtail drain catheters. These are small tubes that drain excessive, unwanted fluid out of an organ within the body. The drain can be used to remove fluid from an area around the heart, pericardial, mediastinal effusions. This is where fluid accumulates continually or over a period of time. It's not typically used for an acute event. The lungs can accumulate pleural effusions, especially in cancer situations. I've just written there abdominal organs as well, even though we're looking at chest X-rays, so we're not going to be reviewing ascites. But pigtail drains can be used for that as well. And pigtails, they're referred to as that because they had a twirl in their tail, just like pigs have, I guess. If a pigtail drain is placed correctly, it's similar to a chest tube. And correct placement is verified if the fluid's draining either from the pleura, pleural effusion, as indicated by the X-ray that you're looking at, the mediastinum, or pericardial fluid from an effusion. Incorrect placement of a pigtail drain, basically the same. If it's not doing what it's supposed to be doing, it probably shouldn't be there, as with everything. If you've got an invasive line going into the body, they all have potential complications or hazards associated with them. So a pigtail catheter, which is placed incorrectly, is considered to be dangerous and can be identified on chest X-ray, but more importantly, there's no drainage. The chest X-ray that you're looking at here, again see, lateral chest X-ray, confirms something that we probably already know from the AP film. The pericardial effusion doesn't drain because the catheter appears to be kinked, which is verified both on AP and on lateral. Okay, another reason why a chest X-ray may be used, certainly in an acute care area, is to confirm placement of an intra-aortic balloon catheter IABP means intra-aortic balloon pump catheter, and it's used for intra-aortic balloon counterpulsation, which means it's essentially helping the heart to function. Now, an intra-aortic balloon pump catheter consists of a long flexible tube with a radio-opaque tip and has an attached balloon, and the purpose is to inflate and deflate. The catheter is inserted into the descending aorta by the femoral artery, or it can be inserted into the carotid artery or subclavian artery into the aorta. But typically the most common is the descending aorta via the femoral artery. And this is a left ventricular assist device that essentially decreases the workload of the heart. On the X-ray here, you can see the radio-opaque tip. You can see the radio-opaque catheter that extends all the way down the descending aorta. If the catheter is placed correctly, as visualized on the chest X-ray, the tip of the catheter should be about 2 to 3 centimeters below the aortic knob or knuckle. It shouldn't go up into the arch. The catheter tip should be level with either the carina, T4, if you can see a posterior rib, the fourth posterior rib intercostal space. If it's a PA film, unlikely, the second anterior rib, but this will typically be a non-AP film. On an AP film, we mentioned in previous Learn shops that it's probably unlikely that we'll see anterior ribs clearly on an AP film because of the way and closeness of the beam to the person being filmed. But the catheter tip, as indicated on the X-ray, should be 2 to 3 centimeters below the aortic arch or knob, indicated by the crescent curve. And the arrow is indicating the radio-opaque tip. Again, level with either the fourth posterior rib intercostal space, the carina. I haven't included the anterior rib here because this is an AP film. Very difficult to see. Interestingly enough here, you can note here that the PA catheter is in way too far. Potentially dangerous. Interestingly enough here, you can look at the ECG electrodes. All over the place. Wires. Which makes it more difficult to try and see what you're wanting to see. If you have incorrect placement, it's potentially dangerous. So for example, not that I'm going into intra-aortic balloon counterpulsation in this Learn shot, if the catheter is placed too low, the balloon can actually obstruct the renal arteries and decrease renal perfusion, and one of the complications might be the patient might go into renal failure. Or if the catheter is placed too high, it can obstruct the subclavian arteries, the carotid arteries, which could impede blood flow to the head and to other parts of the body. But on the X-ray that you're viewing here, the catheter is placed too low. You can see the radio-opaque tip, and this would have an effect lower down on the renal arteries. Or if it's too low, the catheter may not be doing what it's supposed to be doing, helping the heart. It's supposed to be in the right position. If the catheter is placed too high, look, the radio-opaque tip is very, very, very high in the aortic arch, knob, knuckle, which could obstruct blood flow to the subclavian or carotid arteries. But this is a good X-ray. You can see the radio-opaque tip, and you can see the helium in the actual balloon, like a long sausage, going all the way down the descending aorta. Incorrect placement. It needs to be pulled back. So, that's the end of this session for part 5. So let's review line and tube placement on chest x-ray and see what you've picked up. Again, always evaluate all x-rays, chest x-rays, with the patient's history, their physical assessment findings, their clinical findings, any serial x-rays that you might have to compare before and after or now, and remember the technical quality: projection, orientation, penetration and rotation and inspiration. Okay, what do you think? There's a number of things happening in this chest x-ray. However, the arrow is pointing to a radio-opaque tip on an intra-aortic balloon catheter, and the catheter is too low. You've also got a mitral valve there, and you've also got atelectasis in the left lung. Look at this x-ray. What do you think? Yes, you've got a oro-nasal feeding tube, I guess. And is it correctly placed? Wrong. It's incorrectly placed. It's going into the right main bronchus. It's not going into the stomach. It's going into the right lung. Potentially dangerous. What do you think? You got a very black right lung and a very white, patchy, heterogeneous left lung. And you've got a tube going down into the stomach. That seems to be okay, but that's not the problem. The arrow is pointing to another radio-opaque tube, which is the endotracheal tube, and it's going into the right main bronchus. It's incorrectly placed, which is why it's only ventilating one lung and not the other lung. The other lung is atelectic. Okay, look at this chest x-ray. It's pointing to a chest tube, radio-opaque. You can see it very clearly in the right lower lobe. And the other arrow is pointing to the lung, the right lung, which is completely collapsed. Look at the vascular markings. They only go out to where the arrow is pointing, and the rest of the pleura is full of air. However, the x-ray confirms that the pleural tube or the chest tube isn't draining the pneumothorax. So therefore, this is incorrect chest tube placement and needs to be repositioned. Here you've got a pleural effusion, a right-sided pleural effusion. You've got blunting of the costophrenic angles, which we discussed in previous courses. You could hear a meniscus sign, and you've got a pigtail catheter. However, it doesn't seem to be doing what it's supposed to be doing. So therefore, the pigtail drain isn't doing what it's supposed to be doing, so it must be incorrectly placed to drain the pleural effusion. Well, this chest x-ray looks reasonably okay. However, there's a radio-opaque tube with a radio-opaque tip going into the stomach under the left hemidiaphragm. So therefore, I think that everything seems to be okay. and this is correct nasogastric tube placement. This chest x-ray doesn't look too bad either. It's pointing to a catheter that's coming from the right jugular vein into the superior vena cava and terminating approximately at the cavo-atrial junction, level with the carina. So therefore, this is probably correct placement of the central venous catheter. Then you've got a mess. There's a mess on this x-ray. You've got wires everywhere. Makes it difficult to see some things clearly. You've got ECG electrodes on the chest. So therefore, I'd be thinking here now that this is incorrect placement of the ECG dots and cables, which could create artifact or images that you don't want to see on the chest x-ray. Okay, here's a chest x-ray that's highlighting a pulmonary artery catheter. And the pulmonary artery catheter, is it in the right position? What do you think? Is it in too far, or is it in not far enough? We said 1 centimetre before or after the sternal midline. This catheter is in too far. It's incorrect placement and potentially dangerous. Okay, the last chest x-ray you've got a few things happening here, and maybe we will, since it's the last chest x-ray and this is the last Learn shop for chest x-ray interpretation, we'll just review the whole thing. This is a patient obviously post-cardiac surgery because they have sternal wires in situ. They've got an intra-aortic balloon catheter, they've got an endotracheal tube, and they've got a central venous catheter. And they have a nasogastric tube. So, the endotracheal tube seems to be okay. It's placed, we said, medial to the clavicles as a rule of thumb. The central venous catheter seems to be level with the carina, T4, cavo-atrial junction. The ECG electrodes seem to be off the chest. However, the arrow is pointing to the intra-aortic balloon catheter, and the tip seems to be located in the aortic knob. So therefore, the problem is probably that the IABP catheter is too high. Okay, well done everybody. Thank you for joining me on this journey through chest x-ray interpretation. If you've enjoyed these, please check out some of the other Dr. Manny Learn shops on YouTube. And remember, you're not a radiologist. You're a healthcare provider that's interpreting ECGs basically to help you in your clinical practice. However, if you require expert consultation, consult a radiologist. They're the experts.